Hello all, this is your podcast for the conceptual basis of treatment. It is my hope with this podcast to help you understand some of the treatments that are used for a lot of the psychiatric disorders. So I'm going to talk a little bit about psychotherapy and group therapy, individual therapy, some of the background on those. We're going to discuss some other treatments, and I'll give you a little bit of an overview of the neurotransmitter chemicals that are modified in some way, if you will, when we look at the use of some psychotropic meds. So, hopefully it'll give you a good understanding. Psychotherapy is a process by which a trained person applies the principles for establishing a professional relationship with a client who seeks help for psychological problems. Learning or human development occurs throughout this process. The overall goals for individual therapy are for the client to experience less psychological distress, increase self-awareness and self-esteem, and learn more functional ways to cope. While theories, therapies, and styles of practice may vary with the discipline, one common element in psychotherapy is the relationship between the client and therapist. And that relationship between the client and therapist is considered unique. A result of managed healthcare is that cognitive behavioral therapies and strategies, which are most conducive to achieving quick results, have become the preferred treatment. Using cognitive behavioral therapies and strategies as preferred treatments due to quicker results is important. An important trend in treatment research is the effort, or making an effort, if you will, to establish a scientifically sound foundation for mental health interventions. There are 8 main important psychotherapeutic approaches, and your book goes into more detail in these. I'm just going to give you kind of a quick overview. Do you need to know a lot of details about these? Not really. It's my hope that you'll at least understand that there are different psychotherapeutic approaches and just basic differences in some of them. The psychoanalytic psychodynamic approach was pioneered by Freud. I'm sure you've all heard of Freud. This form of treatment explores the client's conscious and unconscious conflicts with past coping behaviors. The goal is to provide insight and integrate repressed conflicts into the personality so that the person can be happier and enjoy improved functioning. Some other therapeutic approaches, cognitive behavioral, and I'll describe more about cognitive behavioral approaches on the next slide. There's behavior therapy, there's client-centered, there's solution-focused. So you'll learn a little bit about different therapy methods as we go along in this course. Cognitive therapy focuses on how clients think about themselves and their world. There are 2 major types, or major cognitive behavioral modalities. And I guess what I want you to know for the background, and you don't have to know this for a test or anything, but that cognitive therapy was developed by Aaron Beck in 1963. So it's been around a very long time. And another kind of type of cognitive behavioral therapy is called rational emotive behavioral therapy, and that was developed by Albert Ellis in 1955. So again, these are old modalities. One of the newest ones is dialectical behavioral therapy, and this was developed really more recently by Marcia Lynam in 1993, specifically for patients with borderline personality disorders. And this approach concentrates a little bit differently. It works a little differently than, the cognitive behavioral therapy methods. And when you look at, when you think about this type of therapy, I'm going to talk a little bit more about this when we get into talking about patients with borderline personality disorder. but the approach of dialectical behavior therapy concentrates on enhancing the client's capabilities, generalizing therapy skills to the client's environment, improving motivation, and decreasing dysfunction, maintaining the therapist's capabilities and motivation, and structuring the environment. Now you can see on the slide that cognitive therapy itself focuses on how clients think about themselves and their world. Behavioral therapy assumes that human responses are learned and therefore may be unlearned. Usually what you see is a combination of cognitive behavioral therapy together. It fuses cognitive and behavioral techniques. And again, when we get into different disorders, I'll elaborate a little bit more on the therapies. When you look at this type of therapy, though, the cognitive behavioral therapy together, it does not explore how a person became a certain way. Instead, it focuses on changing current thinking and behavior. It is results-oriented and defines goals so that progress toward them can be monitored. And you can see that differs a great deal from from Freud's methods, if you will. He thought they were from repressed childhood things, and then you needed to reintegrate those things into the personality. There are some fundamental assumptions for all cognitive behavioral models. Cognitions or thoughts influence a person's responses and affect the degree of adjustment or maladjustment. Conditions can be monitored and altered, and new behaviors can be consciously chosen. Cognitive behavioral therapies are time-limited, and most applications are for specific problems. Cognitive behavioral therapies help to develop skills applicable to other problems. We work a lot on homework assignments, coping skills, those kinds of things, changing negative thoughts to positive thoughts, and so on. So again, we'll talk more about these as we roll out this course. The general cognitive therapeutic approach includes the following: building trust, active listening, and having empathy, turning data into goals or a working problem list, reviewing the past week, deciding on an agenda for each session, working on an agenda, and reviewing the session. There are basic skills that are practiced by the RN psychiatric mental health nurse, and they include the following skills: assessing and recording behavior, administering and evaluating the effectiveness of meds, communicating with other team members, and being in charge of the psychiatric milieu. That's an important word, milieu, and we'll talk more about that in just a little bit. Psychiatric mental health nursing, more nursing interventions, health promotion and maintenance, intake screening and eval, case management, provision of a therapeutic environment, tracking clients and assisting them with self-care activities, administering and monitoring psychobiologic treatment regimens, more meds. We also are involved in health teaching and counseling, crisis interventions, a big part of what psychiatric nurses do, psychiatric rehab, community-based care, outreach activities, and advocacy. RN psychiatric mental health nurses incorporate principles from different psychotherapeutic techniques previously discussed into their general interactions with clients. The psychiatric mental health nurse also helps with scheduling routine follow-up appointments, instructing clients about early signs and symptoms of psychiatric problems. We teach stress reduction techniques. We refer clients to substance abuse awareness programs. We educate clients that positive mental health is a direct function of choices. Here's some examples of intake screening and eval. We assess the client's physical and psychosocial state. We make diagnostic judgments. We facilitate the client's movement into appropriate services. We consider the client's biophysical, psychological, social, cultural, economic, and environmental aspects, and refer the client for additional testing. Some of our interventions that relate to case management include assessing risk, counseling, problem solving, teaching, monitoring medication and health status, providing care planning, coordinating with other healthcare services. Some psychobiologic interventions, and it's not always meds, some more psychobiologic interventions utilized by nurses for their clients include relaxation techniques, nutrition and diet management, exercise and rest schedules. And you'll find, oftentimes with working, for instance, with a bipolar client, it's very important to help them strike a balance between exercise and rest. I want you to take some time at some point to review Client-Centered Education 17.1, Mindfulness Meditation. You'll find that in Chapter 17 of your book. Nurses are also very involved in psychiatric rehab. They promote consumer empowerment and recognition of the role of the family in the larger social network. They focus on accountable programming, cost effectiveness, and outcomes. They form stronger collaborative relationships with treatment services, and they place the emphasis on recovery of hope and development of functional competencies. With individual psychotherapy, there's an agreement between the client and the therapist to enter into a therapeutic relationship. We assist clients, or the therapist assists clients, to identify feelings, make connections between thoughts, feelings, and events, and gain insights. You can see that on the slide. It says the goal, assists clients with coping strategies, reduce stress, manage the crisis. Some individual therapies deal with specific issues like sex therapy. There are many different models of individual psychotherapy, for example, cognitive therapy, interpersonal therapy, and existential therapy, as well as models that combine several approaches. There's also group therapy, and you will probably be able to see some group therapy going on in these settings that you will find yourself in, doing a real little bit of mental health nursing. You'll see group mostly in acute care settings, but it is also used in outpatient settings. When you go to White Deer Run, for instance, you will see group work going on at White Deer Run. What group therapy does is, to just kind of define it, experience in which people with psychological, cognitive, or behavior dysfunctions are helped. And primarily, it can be used with adults, geriatric clients, children, but it gives the people in the group an opportunity to hear each other's points of view. Groups tend to be very supportive. They support each other. Often many members are going through the same things. It's helped through a process of change by the group and the group leader. There are 3 types of groups: task groups, education groups, and supportive or therapeutic groups. Supportive or therapeutic groups provide support to members as they work through problems. The group helps members identify feelings and behaviors they wish to change. The supportive group provides a safe environment for people to work out their particular problems through the sharing of experiences with other members. This is perhaps the most well-known type of group, the supportive or therapeutic group. Task groups are designed to carry out a particular type of task and are problem-oriented. The emphasis is on problem-solving and decision-making. Within the clinical setting, for instance, a task group might plan and prepare a community meal. Education groups teach members about specific topics. For instance, there might be a medication teaching group. Maybe there will be a group, an education group centered around learning coping skills and so on. So you'll see different groups used. The advantages of group therapy, of course, include cost effectiveness. And that's probably the main one. The other advantages, of course, is as I've said before, members benefit by hearing each other's problems. They learn multiple problem-solving strategies. They gain a reference group. They explore their style of communication in a safe atmosphere. Now, groups are most effective when two types of communication match. One is called latent communication. Content is not discussed but occurs on an emotional level and seldom is verbalized, and manifest communication, which involves the spoken word. So again, groups are most effective when these two things match. The disadvantages to group therapy are lack of privacy and difficulty with self-exposure. Nurses use group and group processes in many healthcare and community settings. A couple of problems to group communication: transference and countertransference. Two very important points, words that it's important to not forget those, what transference and countertransference means. Another type of therapy is family therapy. The family therapy is an important consideration of mental health therapy. Often the family is functioning in the primary caregiver role for the client with mental illness. It is important to assess the family's characteristics and gain insight into their strengths and weaknesses. We can do, collect some data about activities of daily living. What are the members' chores and responsibilities? That's the instrumental subcategory. The expressive subcategory includes interaction between and among family members. We look at communication patterns, problem solving, family roles, influence and power of members over others, family beliefs, and alliances. Family interventions include cognitive interventions, trying to change the way a family perceives its situation. Affective interventions, which involve the emotions of the family, and behavioral, which assist family members to interact with one another differently. Again, family interventions include both health promotion measures and steps to improve family functioning. There's the family strength model, and this focuses on the resilience of the family and resources in the environment. And when we get into the clinical aspect a little bit about mental health, even at Arch Street, you're going to see just how important the resilience of the family and resources in the environment are to helping a person get better. The family strength model is based on a collaborative approach. Nurses form partnerships with families to achieve goals. It emphasizes results that families, not nurses, desire because, ultimately it is the family that has to take care of this person perhaps, or this person, is going to be a member of that family, and certainly the family needs to come up with what they think are the ideal results, not what we nurses kind of push on our agenda on them. We have to let the family kind of come to that. Together, families access resources, learn skills, and practice behaviors to improve functioning. Now, there is a family burden, and researchers conceptualize the stresses that families experience when a loved one has SPMI as family burden, serious persistent mental illness. Some families actually recall the exact moment they became aware that something was wrong with their relative, while others are in denial or disbelief. The first diagnosis is not always correct and can be one of many. Many families expect a speedy recovery only to find that their loved ones never fully recover, or that the process of healing is quite lengthy. There are 3 types of family burden. Objective, which these are the practical problems that family members encounter while caring for ill relatives: housing, food, transportation, medication management, money management, companionship and recreation, crisis intervention, mediation with police. Subjective is kind of that emotional component: grief, fear, guilt, anger, and other emotions. And then a 3rd type of burden is called iatrogenic. IATROGENIC. And perhaps you've heard this word before. But this burden is attributable to a flawed mental health system and to the attitudes and behaviors of some professionals who cling to outmoded theories about families and mental illness. In addition to the flawed mental health system, families identify confidentiality laws, involuntary treatment laws, and discrimination in insurance, treatment, housing, and employment as adding to their burden. So when you see families trying to care for a family member experiencing mental illness, particularly severe and persistent mental illness, you see caregiver burnout. You see damaged interpersonal relationships, including broken marriages, developmental delay in younger family members, stress-related health problems for all members. Caregiver burnout and these other factors put clients with severe and persistent mental illness at risk for homelessness. There are also known genetic risks for mental illness, and with those genetic risks for mental illness, oftentimes parents feel guilty when their child, for instance, even as an adult child, has been diagnosed with mental illness. So, that exists as well. Family consultation is a secondary prevention strategy based on the assumption that the model family dealing with serious and persistent mental illness is healthy and competent, but lacks sufficient knowledge and skills. The 3 F's of family consultation: feeling stage. The consultant acknowledges the feelings of all family members and tries to normalize them. The focus stage. The consultant helps relatives set priorities. And finding the solution stage, the consultant takes the lead in finding solutions in concordance with the family. In the role of family consultants, nurses mentor families to expand their experientially based knowledge and to help them access NAMI or other types of organizations that will help them. They also support families with empathetic understanding and help them set priorities and problem solve. They refer them to clinical services including psychotherapy, grief counseling, marital counseling, etc. The knowledge base required by nurses functioning as family consultants includes a thorough understanding of severe and persistent mental illness and treatment. So a lot of things that need to be considered. They need to be empathetic for the family as far as a skill. They need caregiving skills. They need to be aware of government entitlement programs and community resources. These nurses need teaching skills, and they need an ability to communicate with clarity and respect. So here's that milieu word again. Milieu is a word that describes a planned community, often defined more specifically as a therapeutic community in which the entire social structure of the unit or residence is designed to be part of the helping process. Some goals of milieu therapy include emphasis on clients as responsible people, group and social interaction, clients' rights to choose and participate in a variety of treatments, and informality of relationships with healthcare providers. In milieu therapy, communication between clients and staff should be open and honest. Activities are planned to meet individual needs. This is a place where clients should feel safe, secure, and supported. It's focused on recovery, staying well. So for medications, you're going to learn a lot about psychotropic drugs in this course. The basic action of psychotropic drugs is to change the transmission or reception of nerve impulses. In general, this is accomplished by regulation of the level of the neurotransmitter within the synapse with the goal of keeping the correct amount of the neurotransmitter available. We look a lot at the interaction between these three neurotransmitter chemicals, if you will: norepinephrine, serotonin, and dopamine. And it is that combo of these that, if they're all working together and they're all in balance and so on, you have a healthy person that has, an appropriate mood, appropriate level of cognition. But when you get problems with these, well, you can start with norepinephrine, for instance. Energy, alertness, and concentration. But an overabundance of norepinephrine makes a person impulsive. It increases anxiety. It makes them irritable. And serotonin, you've probably heard about. It's responsible a lot for, lack of or low serotonin levels for depression. So again, we'll be looking at serotonin. We'll also look at dopamine. And again, we'll learn more about these three neurotransmitters a great deal as we look at meds and different disorders and such. We will also discuss GABA, G-A-B-A, particularly with anxiety. So again, that's probably the fourth neurotransmitter that's important for your understanding of how these meds work. Client-centered education psychopharmacology, there is a teaching plan, an example teaching plan for you in Chapter 16, so that's a good thing to review as well. So some other therapies, ECT and VNS, and more about them on this slide. I'm going to start first with the second one, vagal nerve stimulation or vagus nerve stimulation. I've seen it written both ways. This is a surgical procedure and is used to treat those with treatment-resistant depression. There's a pacemaker-like device that's implanted in the body. The device is attached to a stimulating wire that is threaded along the vagus nerve. The vagus nerve travels up the neck to the brain, where it connects to areas believed to be involved in regulating mood. Once implanted, this device delivers regular electrical impulses to the vagus nerve. For reasons that researchers don't completely understand, these electrical impulses transmitted via the vagus nerve to the brain can relieve symptoms of depression. They may affect the chemical balance of the brain, but it could take several months before the person actually feels the effects. Now the other is ECT, or electroconvulsive therapy. Typical course here consists of 6 to 12 treatments, usually given 3 days per week. Before a person would have ECT, they would need a complete physical history, neuro exam, chest x-ray, spine x-ray, and lab studies if indicated. So there are some contraindications to electroconvulsive therapy, and these, like brain tumor, recent CVA, subdural hematoma, these can also result in increases to ICP, or intracranial pressure, and you do not want to expose that person that has increased intracranial pressure to ECT. Any severe heart disease or aneurysm, because there's a decrease, or due to an increased risk of complications like arrhythmias and death. There are limitations with ECT as well, and it's not effective against neuroses, thought disorders, personality disorders, or dysfunctional grief reactions. Mortality is about 1 in 10,000. Much of that risk is with general anesthesia. More about that in a minute. The legalities vary state to state. It's usually not considered until after a number of psychiatrists have assessed or tried a certain number of treatment and drug regimens without success. The person must be deemed competent to be able to sign a consent, but they can be judged incompetent to receive ECT involuntary. But even then, a judge must order this, and all other criteria must be met. On the day of treatment, the person is NPO after midnight because this is done in the OR under general anesthesia. They use a systemic ultra-short-acting barbiturate, such as methohexital sodium. Most patients get ketorolac and ondansetron. I can't say that one. Ondansetron before they get their short-acting barbiturate. Ketorolac is Toradol and Zofran. So again, you're giving them something for pain, something for nausea, before they get the short-acting barbiturate. They also use a potent muscle relaxer, succinylcholine chloride, or anectine, is injected IV to induce muscle relaxation. It's actually a paralytic agent. It is a form of, I don't think it's a form of curare, but it's closely related to curare. So it induces muscle relaxation and prevents full body muscular response to the grand mal seizure. The effects last usually 4 to 6 minutes. The person's on a mechanical ventilator and 100% oxygen because anesthesia will prevent spontaneous breathing. In the OR, the electrodes are placed once the patient is unconscious and paralyzed. You can see on the slide electrodes are placed on one side of the temple or both temples through which the current is delivered. During the entire procedure, the client's vital signs and cardiac status are monitored. They give an electric shock, 70 to 150 volts, for 0.1 to 1 second to produce generalized seizure that lasts 30 to 60 seconds. Because of the neuromuscular blockade, body movement is slight. After the procedure, the person is placed on their side to prevent aspiration if they should vomit. Same thing as you do if a person has a grand mal seizure, and not because of electroconvulsive therapy, but just because they have a seizure disorder or whatever. So we place them on their side to prevent aspiration if they should vomit. The other thing about placing a person on their side, and if you ever want to try this, just try laying on your side and try to block your tongue kind of over your airway. Your tongue automatically falls away when you go on your side. They remain in bed 1 to 2 hours with vital signs taken as per institutional policy. One of the other things we need to do as nurses is, reorient them often and reassure them. We're going to assess those vital signs. We're going to orient them. We're going to check for alertness, signs of confusion, and postural hypotension, because postural hypotension is kind of a complication, and that's why we keep them in bed. We need to monitor for that and not let them get up until they are fully recovered. After the procedure, initially after the treatment during the day, the client might complain of muscle soreness or aches and headache. They'll probably have an order for Tylenol or aspirin or, acetaminophen, aspirin, whatever. Memory is affected often, both memory of past events and newly learned information, usually short term. Confusion often clears within an hour, usually resolves after treatment is completed. A few patients might permanently lose memory of the events just before the first therapy session. Within 6 to 9 months, the ability to learn new material returns to normal. Remember that since it is an operative procedure, the client must be fully informed, and then he or she must sign a permit or a consent form. Anytime during the course of the treatment, the client may stop or refuse to take any further treatments, again, unless it is an involuntary deal that a judge has signed off on. Here's just a picture of ECT. And if you ever have an opportunity to be in the operating room and actually observe this, you know, you've probably all seen the old movies and you've seen ECT and it looks just dreadful. But it's really not nearly as bad as you would think it would be. And I don't think I ever told you why it's used a lot, but it's used with oftentimes profound depression. And there are some other uses, but that's probably the most common one these days. And that's the end of your podcast for the conceptual basis of treatment.